Thank you, everyone. Our final session before lunch is a guest lecture on the use of antithrombotics in perioperative care. Chairing this session are Dr. Madhuvanti Hettiarachchi and Dr. P. Sudarshan. Please give them a warm welcome.
Good afternoon, everyone. This is the last lecture before we break down for lunch. And today, our lecturer is Professor Andrew Dunn, MD, MPH, MACP, FSHM, FRCP. And he's currently the Professor of Medicine and Chief of the Division of Hospital Medicine for Mount Sinai Health System. Without further ado, let us invite Professor Andrew Dunn to deliver his talk.
Thank you very much for inviting me here to speak today on perioperative anticoagulation management. It's something many of us see all the time. I've had the great fortune to be in this field for a while, be a member of the ACCP and CHEST panel guidelines, and want to discuss with you some of the highlights. And I know what most of you are thinking. We're right before lunch, and most are thinking, I wish we could spend the whole hour and get to lunch late. Me too. But unfortunately, only give me about 25 minutes. So we'll get through things really fast. So if I go a little fast, that's why there's a lot to get to. The goals, we'll talk about the factors when determining whether to bridge someone who's on warfarin. Warfarin used a lot less often these days, but still we do have some patients on it. The timing of management of the DOACs, the direct oral anticoagulants, going for procedures. We'll talk a little bit about antiplatelet therapy. And if we have time, we'll hit on at least one of the antidotes. So we'll start with a case, an 80-year-old female, hypertension, diabetes, AFib, dialysis. No history of TIA, stroke, or bleeding. She's on warfarin. Her INR is 2.5, so you know it's a hypothetical case. And she's going to undergo elective major abdominal surgery. So you're thinking, this patient's on warfarin going for major surgery. What do I do? Am I going to bridge? So what goes through your mind? First is, what's the risk of thromboembolism during those days that she's off of her anticoagulants? Is it high? Is it low? What's the risk of bleeding? And to be precise, that's the risk of postoperative bleeding if you give full dose anticoagulation soon after surgery. What are the consequences? Consequences of thromboembolism in AFib is often a devastating middle cerebral artery stroke, which can leave you disabled 2/3 of the time, or bleeding, which is most often controlled. And what's the efficacy of bridging? What's the data? So I'm going to go through this a little bit fast. And this is the CHEST guideline. I'm lucky to be a panelist on this group. It was a very fascinating process to put together. And you can read, it's a great resource to see. You should bridge, the bottom line is you should bridge patients who are very high risk. With AFib, that really is limited to patients who had a stroke or TIA in the last 3 months. If you have AFib and a recent stroke, you have to consider bridging. Everything else becomes real expert opinion, which you should take a little bit more with a grain of salt. Very high CHAD score, CHAD-VAS score, rheumatic valvular heart disease also fall into the high-risk category. Well, what do we know about bridging? Well, we know it's harmful. That's for sure. And here's one meta-analysis looking at it. You can see the black diamond is off there to the right, which says you triple your risk, or 3 to 4 times increase your risk of major bleeding when you bridge someone. So bridging, when you're stopping the warfarin, giving low molecular heparin, warfarin, or IV heparin pre and post, causes bleeding. We also know there's some procedures where you should just continue therapeutic anticoagulation because the risk is kind of low. Cataracts, not a very vascular space, you should continue anticoagulation. Removing 1 or 2 teeth, do not need to stop anticoagulation. If your dentist says you do, tell your patient to find a different dentist. Arthrocentesis, joint injection, you can do also safely. Endoscopy, colonoscopy, with or without biopsy, you can do safely. I like this study mostly because of the acronym, the dentist trial, and it takes a lot of data we had in the warfarin era and shows you that even with the direct oral anticoagulants, it's safe to remove teeth. Here, the experience with warfarin, 21 patients, 50 extractions, no major bleeding. With the DOACs, 86 patients, 145 extractions, no major bleeding. So that tends to be safe. You can tamponade with gauze. You can use tranexamic acid and make that a very safe procedure. I'm just going to highlight here, this is a study of polypectomy and colonoscopy. And just to point out that the bridging group, which is heparin bridge, that's this. I did that last time too. There we go. I think this is the right one, maybe. Yeah. 12%, HB, 12% risk of major bleeding and bridging, while continuing anticoagulation, 5%. So bridging can cause more bleeding than continuing anticoagulation straight through. So what's the data show in bridging for AFib? There's one major trial. I was lucky to be one of the authors on this. This is a randomized trial. It was in the New England Journal of Medicine. Patients were randomized. Everyone stops their warfarin. One group goes on placebo. One group goes on low molecular heparin before and after surgery. The hypothesis going in was that bridging is not effective and might be harmful. And that is pretty much what was found. If you take a look at the thromboembolism rate, very low in both groups and no different, no benefit from bridging. And if you look at the major bleeding rate, it does go up. Major and minor bleeding is increased with bridging in atrial fibrillation. So our patient, the guidelines say the CHAD score was 3. The new guidelines say don't bridge because it's intermediate risk. So we don't bridge this person. And in general, don't bridge most patients with AFib unless they've had a recent TIA or stroke. Really fast on venous thromboembolism, we can go through the data, but sometimes I point out, Frida Kahlo was a famous painter, Mexican painter. She was in a bus accident, crushed her leg, had polio, so she was fairly disabled, and died of a PE after her leg amputation. So VTE we know is very common. The guidelines are very similar. If you've had a VTE within the last 3 months, your patient, that's someone you should consider bridging therapy for. Otherwise, again, it gets into more expert opinion. A very potent thrombophilia off here to the right at the top, you would consider bridging, such as lupus anticoagulant. Your less potent thrombophilias like factor V Leiden or the prothrombin mutation are not high-risk features. They're intermediate risk features, and bridging probably not indicated. If you've had one VTE and it was in 1979, the patient does not need bridging therapy. Probably doesn't need to be on anticoagulation at all. And this is one very large meta-analysis of patients with a history of VTE, also showing that bridging is ineffective and unhelpful. You can see the recurrence rates with bridging or no bridging are very low and similar, while you do get more bleeding if you choose to bridge. So similar theme, bridging, the benefit is small and there is harm. What about mechanical heart valves? The last group we'll talk about on warfarin. This person, 78, hypertension, heart failure, aortic stenosis, mechanical tilting disc aortic valve. I'm going to go for nephrectomy for renal cell carcinoma. So the golden rule on bridging mechanical heart valves is to bridge. That's nice and easy. But is that always the case? The answer is no. There's one valve that's fairly low risk, and that's the bileaflet valve, which you can see up here at the top. The risk per year on anticoagulation is very low, 0.5% per year. And the aortic valve is generally lower risk than mitral due to the high flow state. So a bileaflet aortic valve that is relatively older, over a year, is a low risk valve, especially if there's no other risk factors like AFib or CHF that you can see on the bottom. So a bileaflet valve in the aortic position would not need bridging. So there is one, but all other cases you probably would. There is one trial looking at this. It was the PERIOP-2 trial, mostly looked at AFib patients, but had about 300 patients with mechanical heart valves randomized to placebo or to bridging therapy, which did not find a benefit to bridging therapy. Now, 300 patients in this realm is very small, and only a third of them were mitral. Some of them were aortic. So I don't put a lot of stock in this to say we should not bridge all mechanical valves, but it does raise some controversy. And the controversy raged into the CHEST guidelines. And if you can read this, and I'll read it for you, it says, in patients receiving warfarin therapy for mechanical heart valve who require interruption, we suggest against bridging. That's for mechanical heart valve. So patients who are on vitamin K antagonist therapy for mechanical heart valve, we suggest against heparin bridging. Wow, that's a bit of a shocker, right? But if you look closely at the same guideline, it says in patients receiving vitamin K antagonist therapy who are at high risk for thromboembolism and require interruption, we suggest bridging. Okay, so that seems to contradict itself. And who's at high risk? Well, just about everybody with a valve. Any mitral valve, period, is high risk. A cage ball tilting disc in ball is higher risk, and if they've had a recent TIA or stroke. So who's not at high risk? An aortic bileaflet valve with no risk factors. And those patients wouldn't need bridging. Everyone else, I would say, probably should undergo bridging. Again, we're moving fast, and that's warfarin. And I go through that quickly also because, thankfully, warfarin is less commonly used modern management. We're going to shift to the direct oral anticoagulants. Another case. 75-year-old woman, hypertension, diabetes, HFrEF, AFib, CKD stage 5, bladder cancer. Going to go transurethral resection of bladder tumor under general anesthesia. Exam is pretty unremarkable. Heart rate's irregular. Her medicines are listed here. Lantus, Lispro, Losartan, Carvedilol, and apixaban and aspirin. Hemoglobin is 10. Creatinine's 3.3. GFR is 14. Very low. Very bad CKD. Very bad CKD. So how are you going to manage this person on a DOAC going for major surgery? When do you stop? When do you restart? First thing I'll say is she's on apixaban and aspirin, and one little side pearl here is stop the aspirin, and stop the aspirin for good. If you have someone who is on aspirin for any indication except stents, see, they've had CAD, they've had MI, they have whatever, PAD, and they're on an aspirin. Now they have an indication for an anticoagulant. They no longer need the antiplatelet. You're multiplying the risk and without extra benefit. So this person probably no longer needs to be on an aspirin at all. But how do we manage the DOAC? First, you can Google this, but this comes from the ISTH, International Society for Thrombosis Hemostasis. You'll find easy lists of what category your patient's bleeding risk is. No need to memorize 1,400 procedures. You'll get it off of this. Here, a GU procedure is a high bleeding risk procedure. So that's the first important step. So now you have someone with really bad kidney function going for a high bleeding risk procedure. How are we going to manage the DOAC again? The best trial from this comes from the PAUSE trial. And what Jim Duquetis and his colleagues did at the time was pharmacokinetically came up with a plan for when to stop and when to restart based on the physiology of the DOACs in general. Not a randomized trial, no control group. They said, let's do this for an awful lot of patients at a lot of centers and see how they do. So this was 3,000 patients on a variety of DOACs. And they used a very sensible regimen. It looks a little complicated. This is when to hold and when to restart. Two important things about this slide. One is the PAUSE trial excluded anyone with a GFR less than 25. So our patient is not here. Okay, that's number one. Number two is I'm going to make this management a lot easier for everybody by eliminating half of it. Post-op, you start the DOAC, restart the DOAC as if you were starting bridging, which means if it's a low bleeding risk procedure, you start the next day. And if it's a high bleeding risk procedure like our patient, you start 2 or 3 days after. Okay, we're halfway done. That's post-op. So in Our Lady, we would start day 2 or day 3, depending on how she's doing. Pre-op, you're going to hold for 1 day for minor surgery. You're going to hold 2 days for major surgery. And it gets a little bit longer for dabigatran due to the half-life. Not to memorize any of that, but just to give you a general framework for how we manage the DOACs perioperatively. 1 or 2 days based on the intensity of the procedure. Now, how do you build in renal function? Well, PAUSE extended that duration of holding, if you probably can't see it, but here it is, for dabigatran with GFR between 25 and 50. So a low bleeding risk for surgery, instead of holding 1 day, you hold 2, and high, instead of holding 2 days, you hold 4. So can we extrapolate? And the results were very good. So they applied this to 3,000 patients and found very low risk of major bleeding, very low risk of arterial thromboembolism. It is an excellent framework to use for our patients. Uh-oh. Let's see my buzz out of that. Okay, we're back. How do we adjust for patients with really bad kidney disease who are on a DOAC? The best guide I use, and I did this something similar even prior to this coming out. This is hot off the guidelines. This is the ACC-AHA guideline. And basically, this just came out recently for cardiac perioperative management, but it does include a section on the DOACs. And basically, pre-op, you're holding for an extra day or two. And I'm not going to have time to go through it in detail, but if you take a look at apixaban, edoxaban, rivaroxaban, this is with normal renal function or moderate to normal. With poor renal function, creatinine clearance less than 30. Instead of holding, 1 day, you're holding for 2. And with a high bleeding risk procedure, instead of holding for 2 days, you're holding for 3. the bottom line is the patient kidney function is really, really poor. You're holding for an extra day. That's an oversimplification, but it's a good rule of thumb. So high quality evidence of how to manage our patients on DOACs with end-stage who are on dialysis is not really available. You're going to extend the pause duration. Use pause, I recommend it highly, or use the ACC-AHA one that I just showed you, and you're going to end up holding a little bit longer before major surgery. For our patient, we'd be holding it for about 3 days prior to major surgery. And you restart at the standard interval, which I mentioned is 2 to 3 days after major surgery. Okay, quick breath, a very short breath, and we're going to move on from DOACs to the antiplatelets. And your antiplatelets, this is, for antiplatelets, I'd like you to risk stratify antiplatelet patients the same way you risk stratify patients on anticoagulation. So you have patients at low risk, that's primary prevention, patients at moderate risk, that's secondary prevention, meaning they've had CAD, they have an MI, they've had a stroke, or they've had PAD, they've had a CABG, and high risk, stents. So right away, your patient comes in to you on antiplatelet medication. Where do they fall? Is it primary prevention, secondary prevention, stents? That's the first thing going through your mind. The best, for primary prevention, it's easy. Hold the aspirin. They probably shouldn't be on it anyway. Secondary prevention is debatable. Interesting controversy. This comes from POISE 2. About 10,000 patients randomized to continue their aspirin perioperatively versus hold their aspirin perioperatively. And if you would have asked me before this trial came out, and these are all patients who had vascular disease, CAD, MI, CVA, PAD, I would have said aspirin's going to be helpful and the risk is probably very, very small. That was my practice at the time. And it's rare for one study to sort of change your practice. And that came out and unfortunately did not show any benefit. The risk of death or non-fatal MI was 7% in both groups. 10,000 patients, that's a very large RCT, right? That's really good data. And there was about a 1% increased risk of bleeding if you're on aspirin. The pulmonary embolism prevention trial was a PE trial of aspirin in patients going for orthopedic surgery. A secondary outcome there was MI. A large randomized trial, aspirin versus no aspirin, showed no benefit in MI also. You put these together, you'd think, okay, secondary prevention doesn't help. Now, the guidelines are mixed. And this actually is the statement from the prior one. The statement from the new one is very similar. It's conflicting. If you read the text, it says, routinely continuing aspirin is not recommended for all patients. And if you read the table, which a lot of people like me like to go to the table, it'll say, consider continuing aspirin if the risk, if the benefits of vascular disease outweigh the risk of bleeding. Again, the guideline a little bit conflicting. Up to date, we'll tell you to hold it because there's no benefit. So it depends on what source and what guideline you want to look at. So the data supports holding it. The guidelines are mixed. I tend to hold. Now, lastly, your highest risk patients. Your patients have stents. They're on dual antiplatelet therapy. They're on 2 agents. They're on for a very variable duration of time, depending on your cardiologist of the day. There's now good randomized trials in this space. And if you take a look, so the question is really how long do they need to be on DAPT? And basically, the more studies we come to, the more we realize that shorter DAPT tends to be better. This is a very large meta-analysis. The little diamond there at the bottom is off to the right, favoring shorter DAPT, and then if you, with no difference in MI. This was another meta-analysis showing that death, you see the diamond there is off to the left, favoring shorter DAPT for death with no difference in MI. And you can really get very short. This is now we're looking not just at, is 6 months okay, maybe 3 months is okay. Roxana Mayrolan, she's one of the cardiologists at Mount Sinai. She led this international study. Everyone's getting dual antiplatelet therapy for 3 months. Then one group continues ticagrelor, and one group gets only one group continues DAPT, ticagrelor, and aspirin, and the other group gets only the ticagrelor, which is a very potent antiplatelet agent. And basically, it showed that if you stop DAPT at 3 months and then continue the potent agent, what you get is less bleeding and no difference in death and vascular outcomes, which is great, because bleeding is the main concern. So perhaps we can shorten even to 3 months. And I'm just going to move on to this one. Now, a study just came out a couple of months ago which said less than 1 month of dual antiplatelet therapy might be okay after a drug-eluting stent. And this was a study looking at patients seen in the first month, and if they were doing well, one of the agents was stopped, and they continued on, I believe it was ticagrelor here. Again, not the aspirin, but the more potent of the two agents. And you can see on the left, stopping DAPT is beneficial. It reduces the composite outcome of death, MI, stroke, thrombosis, or bleeding dramatically. All of this benefit comes from decreased bleeding. All of it. So DAPT causes bleeding, we know this, and the shorter DAPT will decrease your risk over time, including perioperatively. So how do we handle intracoronary stents? A bare metal stent, if they're used 1 month, you should delay surgery for 1 month, delay for 6 months after a drug-eluting stent. When you're outside that window, you're going to continue the aspirin and hold the P2Y12 inhibitor like clopidogrel or prasugrel or ticagrelor. If you're inside the window and you can't delay, you can ask the surgeon if they can operate on both agents. They're going to say no. And if you're in the window, you can, one thing you can do is continue aspirin and hold the P2Y12 inhibitor. If you're like at 3 months, you talk to cardiology, most of the time they're going to say, fine, the data suggests 3 months is going to be plenty. So if you can't delay surgery for 6 months, most likely you can operate at the 3-month point. If you can't delay and you need full platelet inhibition, you're going to bridge with IV cangrelor with your cardiologist. I'm going to skip this because I know we're running close on time. I'm going to just mention this real briefly. So we talked a lot about dual antiplatelet therapy. What about single antiplatelet therapy? So now your patient comes to you, they're on one agent, but it's not aspirin. If they're on aspirin, they'll operate on aspirin, right? But if they come to you and they're on ticagrelor or clopidogrel, which is Plavix, most surgeons do not want to operate on it. There's one study which showed that you can operate on it, but very small, and most surgeons are not convinced. So what do you do if someone's on Plavix, clopidogrel? Do you continue it straight through? Most surgeons will be very hesitant. Do you stop and start aspirin while the patient's off of that other agent? Do you use cangrelor? That's very expensive. Do you reverse? There is a reversal agent, which is a monoclonal antibody that we don't have a lot of time to discuss. So the right answer here may be you change them to aspirin for the perioperative period. It's cumbersome, but it may be the right choice for some of our patients if they're on an agent that they cannot operate on. And I think in the interest of time, I will probably skip through the, do I have a minute or do I have another minute? I'll just mention one because it's really hot off the presses, which is andexanet alpha for major acute bleeding for patients that are on apixaban and rivaroxaban. This was in the New England Journal of Medicine. It showed pretty good effectiveness, but there was the thromboembolism rate as a side effect of this reversal agent was 10%. And which is high. It's also very costly. It's $23,000 a dose. So if you want to reverse, the best time to use a reversal agent with the DOACs is with someone who needs urgent surgery or intracranial bleeding. And the trial that was just published was the New England Journal of Medicine, which came out with this big headline. It reduces the size of the expansion of the intracranial hematoma. And a lot of people would think, great, we need to start using andexanet alpha very liberally for our patients on these agents who need urgent reversal. Unfortunately, the study did not look at outcomes that a lot of us care about, like neurologic function and mortality. And there was, again, an increased risk of thromboembolism, 10% risk of thromboembolism after the dosing, and no change in mortality. So with that, I thank you for paying attention to our whirlwind tour through perioperative management. Our take-home points were AFib. Don't bridge most patients unless they had a stroke in the last 3 months. Mechanical valves, you're going to bridge those patients unless it's a bileaflet aortic valve and no other risk factors. VTE, you're going to bridge, again, those patients who've had a VTE within 3 months. Antiplatelets, big debate on secondary prevention. To me, the data suggests hold, there's no benefit. And drug-eluting stents, most commonly, you're going to wait 6 months, then continue aspirin, hold the P2Y12 inhibitor, but waiting only 3 months is going to be acceptable for most of our patients. And for DOAC, you're going to hold it and restart 1 or 2 days perioperatively based on the extent of the surgery, and hold 1 or 2 days longer for our patients with severe CKD or dialysis. Thank you very much.
In the interest of time, no questions are allowed. So on behalf of Sri Lanka College of Internal Medicine, I express a sincere thanks to Professor Andrew Dunn for the very informative lecture. So may I invite Dr. Madhuwandi Hettiarachchi to present the certificate of appreciation to Professor Dunn.